You would think that in modern medicine, a rule is just a rule.
Right. You'd certainly hope so.
Yeah, like if a clinical trial document explicitly states that having a certain medical device completely disqualifies you from a specific treatment, then a local clinic shouldn't be telling you it's perfectly fine to just walk in and get it done.
Exactly. It sounds like a massive liability.
It really does.
Hmm.
But when we started digging into the stack of sources you sent us, I mean, we're talking dense clinical guidelines,
Right.
clinic FAQs, intense regulatory safety warnings. All of that black and white logic just completely goes out the window.
It really is a wild landscape to navigate.
And your mission for us today, the goal of this deep dive, was to answer one very specific question for you. Does having a hormonal IUD affect your eligibility for vaginal laser treatments?
Which on the surface sounds like a simple binary yes or no question.
Right.
But actually answering it requires us to untangle this massive web of clinical marketing, anatomical boundaries, and frankly, a severe lack of long-term sham-controlled data.
Yeah, and the deeper we dug into your sources, the more we realized that pulling this single thread uncovers a huge contradiction in the medical world.
Mm-hmm.
So today, we are going to explore the sort of wild west of vaginal energy devices.
Mm-hmm.
We'll look at how your reproductive anatomy acts as a biological shield, and we'll break down how IUDs can complicate or even enhance other pelvic procedures.
It's a fascinating topic.
It really is. So let's just start with the most glaring contradiction right at the top of the documents you provided.
The clinical trials versus the clinic brochures.
Yes, exactly. So on one hand, you have a Standard Watch clinical trial listing for vaginal radiofrequency,
Mm-hmm.
and you also have an MDEG best practices document.
Right.
Both of those explicitly list the presence of an IUD as a strict contraindication, meaning it is an absolute exclusion criterion. You have an IUD, you cannot participate.
It's a hard no.
A very hard no. But then on the other hand, we have these clinic FAQs you found from places like Avant Gynecology, Femilift, and Westside Women's Health. And they are actively telling patients that having an IUD is no problem at all.
Which is incredibly confusing for a patient trying to do their research.
Exactly. So, okay, let's unpack this. How can a medical device be a strict exclusion criterion for the researchers, but totally, completely fine for the practitioners who are actually charging money for the procedure?
Well, to reconcile those two very different stances, we really have to map out the physical anatomy. And one of your clinic sources actually uses a great analogy for this. They describe the cervix as a bank vault door.
Oh, right, like a heavy physical barrier between two separate rooms.
Precisely. So an IUD sits inside the uterine cavity, that is the inside of the vault,
Yeah.
and the laser or the radio frequency treatments we're discussing, those are applied to the vaginal cavity, which is the room outside the vault.
Got it.
Now, the cervix and the uterine wall are made of extremely thick, dense, firm tissue. They provide a very robust physical blockade. So the energy from the laser simply does not penetrate deeply enough to ever reach the IUD.
Okay, so the only scenario where the IUD becomes a risk factor is if the anatomy itself has somehow structurally failed.
Right, like if the uterus is actively prolapsing into the vaginal canal, or if the IUD has migrated out of the cavity and is physically poking through the cervix.
Wow, okay. So as long as the vault door is closed
Yeah.
and the vault hasn't, collapsed, the items inside are perfectly safe.
That's the logic, yes.
But wait, that raises another question. If it's just about a physical barrier, why do the clinical trials care so much? Does the actual material of the IUD play a role here? Because, we are talking about shooting thermal energy into the body.
The material is actually the crucial variable. Hormonal IUDs, like the Mirena you mentioned, they don't contain any metal parts.
Oh, really? None at all?
None. They are manufactured entirely from medical-grade plastic and are designed to just slowly release levonorgestrel over time.
Right, which is a synthetic progestin hormone that works locally to thin the uterine lining and thicken the cervical mucus.
Correct. And because the device is purely plastic and hormone, it is inherently safe from radio frequency energy. There's literally nothing there to conduct heat and nothing to interfere with electromagnetic waves.
That makes total sense.
But you have to contrast that with the FDA label you provided for the Mudela IUD. Now, that is a copper IUD.
Okay.
And the FDA label for that specific device strictly warns patients to inform their doctors before undergoing any medical diathermy.
Diathermy, meaning the use of high-frequency electric currents to produce localized heat inside the body.
Yes.
So obviously, you do not want a piece of highly conductive metal, like copper, sitting inside your uterus, acting as a literal antenna for that heat.
Exactly. It creates a severe risk of internal thermal burns. Now, some clinics, Avant Gynecology comes to mind from your sources, they maintain that the uterine wall is so thick that it protects even metal-containing IUDs from their specific treatment.
Really? Even the metal ones?
That's their claim. But clinical trials are designed entirely around minimizing liability and eliminating unknown variables.
Right.
And having conductive metal inside the body during an energy treatment is a massive, unnecessary variable. So researchers use a blanket exclusion just out of an abundance of caution.
While the local clinics are just looking at the practical anatomy of a plastic IUD hiding behind a thick cervical wall and concluding the real-world risk is essentially zero.
That's exactly where the disconnect comes from.
Okay, well, the vault door protects the plastic IUD. The anatomical physics makes sense, but I want to zoom out for a second because we have to look at the motivation here.
Okay.
If this treatment involves firing lasers or radio frequency waves directly into the vaginal canal, what is driving the demand for it? Why are women seeking this out?
The primary driver is a condition known as genitourinary syndrome of menopause, or GSM.
Okay.
Clinics also market it for postpartum laxity and mild stress urinary incontinence.
GSM makes a lot of sense. I mean, when a woman goes through menopause, her systemic estrogen levels plummet.
Right.
And estrogen is what keeps the mucosal tissues in the vagina and urinary tract thick, elastic, and, lubricated.
It's vital for that tissue health.
So without it, those tissues thin out, they become fragile, they become incredibly dry, and that leads to chronic discomfort, burning, and severe pain during intercourse. But the standard protocol for that is usually localized estrogen creams, isn't it?
Yes, topical estrogen is absolutely the gold standard. However, not every patient is actually a candidate for localized hormones.
Oh, like who?
Well, breast cancer survivors, for example. Especially those with hormone receptor positive cancers, they're often advised by their oncologists to avoid even topical estrogen.
That makes sense.
And honestly, some patients simply prefer non-hormonal interventions, so that specific population is where these energy-based devices really found their market.
Got it. And looking at your sources, they primarily focus on fractional CO2 lasers, which operate at a wavelength of 10,600 nanometers, and non-ablative ear-Y EAG lasers, which operate at 2,940 nanometers.
Those are the two main workhorses in this field, yeah.
But what do those specific numbers actually mean for the tissue? I imagine the wavelength dictates how the laser interacts with human cells.
It dictates exactly how the light is absorbed by the water inside the mucosal cells. The goal of both of those wavelengths is to penetrate roughly 500 to 600 micrometers into the tissue.
Okay, and what does it do once it's in there?
It causes controlled thermal injury.
Controlled thermal injury. I mean, that sounds like you are weaponizing the body's own defense mechanisms.
Well, that is essentially the foundational mechanism of all aesthetic medicine.
Right.
The laser fires these microscopic columns of heat into the tissue. This physically causes protein coagulation and localized tissue necrosis.
Which means cell death.
Exactly, microscopic cell death. And by intentionally traumatizing this tiny grid of tissue, the laser tricks the body into initiating a massive wound healing cascade.
Oh, wow. Which means the body rushes fibroblasts to the area to produce fresh collagen, and it triggers neoangiogenesis.
Right, the formation of brand new blood vessels.
That's fascinating. So
Yeah.
they're essentially applying the exact same logic as facial microneedling or chemical peels, but to the vaginal mucosa.
That's a perfect analogy, yes.
You damage the old thin tissue, so the body is forced to replace it with fresh, elastic, collagen-rich tissue.
The physiological logic is identical, and if you look purely at the short-term data from your sources, the results actually seem to validate that logic.
No, I saw that.
Some of the cited studies show patients' vaginal health index, or VHI, effectively doubling after treatment.
And the vaginal health index measures 5 specific metrics, right? Elasticity, fluid volume, pH levels, epithelial integrity, and moisture.
Correct. Each is scored from 1 to 5.
So if a patient's overall score jumps from, say, a 10 to an 18, we are talking about a massive, objectively measurable restoration of tissue health and lubrication.
Absolutely. For a patient suffering from severe chronic GSM, a doubling of their VHI score represents a truly life-changing return to normal daily function.
Okay, wait. If the VHI scores are doubling, and this provides a hormone-free alternative that genuinely rebuilds tissue, this sounds like a massive medical breakthrough.
It does sound that way.
But then I'm looking at this 2018 FDA warning you highlighted in the sources, and the FDA sounds downright panicked about these devices.
They definitely issued a very strong statement.
Yeah, a severe safety communication, explicitly warning against using energy-based devices for quote-unquote vaginal rejuvenation. So where is the disconnect here? How do we go from doubling health scores to severe federal warnings?
The disconnect lies entirely in the gap between short-term symptom relief and long-term verifiable safety. And the FDA is not acting alone here either.
Right, the other guidelines.
Yes. Your sources also include guidelines from the UK's NICE, which is the National Institute for Health and Care Excellence, and an international consensus document from the ICS and ISSVD.
And what do they say?
They uniformly state that these lasers should absolutely not be routinely offered outside of rigorous clinical trials.
But why? If the tissue is physically healing, what exactly are they so worried about?
They cite a severe lack of long-term sham-controlled evidence.
Right. And a sham control means having a control group where the laser probe is inserted into the patient, but the laser isn't actually fired, just to rule out the placebo effect.
Exactly. You need to know it's the laser doing the work, not just the physical stimulation of the probe. But more importantly than that, the FDA maintains a system called the MUDE database.
The Manufacturer and User Facility Device Experience Database.
Right. It's where adverse medical device events are officially reported. And the MUD database for these specific vaginal lasers contains reports of third-degree burns, severe scarring, and worsening dyspareunia.
Worsening dyspareunia, meaning pain during sex.
Yes.
Which means the laser is actively causing the exact symptom that is being heavily marketed to cure.
In a subset of patients, yes, unfortunately. Look, when you repeatedly denature collagen and cause thermal necrosis and a highly sensitive mucosal membrane, you run the risk of replacing functional, stretchy tissue with rigid scar tissue.
I do want to look at the counter-argument from your sources, though, because I think it's important to represent both sides.
Of course.
The Women's Health Clinic, or TWHC, explicitly pushed back against the FDA's warning. They pointed out that CO2 lasers actually have a 35-year safety record in the medical field.
They did make that point, yes.
And their argument was that the FDA's language was just overly alarmist. They said comparing a high-powered surgical CO2 laser, which, a surgeon uses to literally vaporize cervical cancer cells, to a low-power fractional laser used for tissue rejuvenation is, quote, like comparing a car to a bike.
It's a very catchy PR line.
Right. They're basically arguing that just because the surgical laser can burn you, it doesn't mean the rejuvenation laser carries that same risk.
Well, TWHC is identifying a real nuance in the power levels, but they are completely sidestepping the physiological reality of the anatomy.
How so?
It is entirely true that CO2 laser technology is decades old. It's well understood by physicists. But what the FDA and INICE are pointing out is that applying this technology specifically to treat GSM is a highly novel application.
Right.
The vaginal wall is not the epidermis on your face. It is a very thin, very dynamic mucosal membrane situated mere millimeters away from the bladder, the urethra, and the rectum.
Okay. So the technology itself is mature, but pointing it at this highly sensitive anatomical neighborhood is essentially experimental.
Precisely. Now, we do have clinics in the Frontiers cohort study you shared reporting 0 serious adverse events across more than 2,000 laser sessions.
Which is impressive.
It is. The short-term healing cascade is clearly happening for many women, but we simply do not have the data on what happens to that vaginal tissue 5, 10, or 15 years after it has been repeatedly thermally injured.
So the marketing claims for vaginal rejuvenation has just vastly outpaced the slow, methodical pace of clinical safety data.
That's exactly the issue.
Well, that brings us right back to the overarching theme of anatomical boundaries. The IUD is shielded from the laser because it sits behind the cervix. The laser stays in the outer room. But your sources also detail what happens when treatments actually do have to interact with that vault door directly, like loop diathermy, for instance.
Yes, the clinical guidance you found from Guy's and St. Thomas's NHS Trust regarding the treatment of abnormal cervical cells.
Right. Now, if the laser is just causing controlled microscopic burns, loop diathermy seems much, much more aggressive. What exactly is that procedure doing that requires a completely different set of rules for an IUD?
Loop diathermy uses a very thin wire loop that's charged with an electrical current to physically excise or, cut away abnormal tissue right off the cervix.
Oh, wow.
So in this scenario, the cervix, the vault door itself, is the actual surgical field.
And the strings of the IUD hang down from the uterus. Directly through the cervix, right into the vagina.
Right. So you physically cannot perform an electrical wire excision on the surface of the cervix while the plastic strings of an IUD are passing straight through your cutting path.
It's a literal physical obstruction.
Exactly. So the NHS guidelines note that the clinician will likely have to remove the IUD entirely during the treatment, and then the patient must wait at least 4 weeks for the cervix to heal before having a new one refitted.
Which I assume is to avoid introducing any infection into a fresh surgical wound.
Precisely.
Okay, so if the treatment is in the vagina, the IUD is fine. If the treatment is on the cervix, the IUD has to go.
Right.
But then I saw the notes you included from Dr. Melissa Buttini regarding endometrial ablation. And in that procedure, it seems like the IUD goes from being an annoying obstacle to being an actual surgical tool.
Yes, endometrial ablation is a fascinating procedure. It physically destroys the endometrium, which is the lining of the uterus, to treat chronic, very heavy menstrual bleeding.
Okay.
It's an intervention often utilized by women who are trying to avoid a full hysterectomy.
So for this one, the surgeon has moved past the vagina, they've gone past the cervix, and they're operating entirely inside the vault.
Exactly, and Dr. Buttini points out a highly effective synergy here. A Mirena IUD can actually be inserted at the exact same time the ablation is completed.
Wait, how does that synergy work? If you just surgically destroyed the tissue, why put an IUD in right on top of it?
Because the physical ablation destroys the bulk of the tissue, causing the heavy bleeding.
Right.
But the endometrium is incredibly resilient. It can sometimes try to regenerate. So by leaving a hormonal Mirena IUD behind in the vault, it continuously releases levonorgestrel directly into the uterine cavity.
Oh, I see.
That localized progestin completely suppresses any remaining endometrial cells, preventing the lining from ever growing back while simultaneously providing highly effective contraception.
I mean, that is just a masterclass in utilizing the anatomy. The hormonal IUD is perfectly safe from the vaginal treatments. It's a temporary physical obstacle for the cervical treatments, and it's a synergistic secondary therapy for the uterine treatment.
It's a very versatile device.
It really is. But, all these interventions we're talking about, the lasers, the diathermy, the ablations, the IUD placements, they all involve a fairly heavy physical burden placed almost entirely on the female patient.
It's a very valid point.
And the sources you provided, they don't just stop at managing reversible contraception. They also tackle what happens when a patient wants a permanent solution, so they never have to navigate this vault door math again.
Sterilization, the ultimate intervention.
Right.
We spend so much time debating the nuances of reversible methods, but it really is illuminating to look at how the permanent procedures compare, particularly when you look at the FSRH, the Faculty of Sexual and Reproductive Healthcare guidance on male versus female sterilization.
Yes, the FSRH guidance have a very specific mandate that stood out to me immediately.
About the risk disclosure.
Yeah. It legally requires medical professionals to inform their patients that a vasectomy is safer, it's quicker to perform, and it carries significantly less morbidity than laparoscopic female sterilization.
It's a very strong mandated disclosure of risk disparity.
It's not just a casual recommendation. But what does morbidity actually mean in this specific clinical context?
Morbidity generally refers to the rate of disease, complications, or physical trauma associated with a medical procedure.
Okay.
Laparoscopic female sterilization requires the surgeon to physically enter the abdominal cavity to access the fallopian tubes. This almost always requires general anesthesia, and breaching the abdominal wall inherently carries risks of internal infection, organ damage, and just a prolonged painful recovery.
Whereas a vasectomy is happening entirely on the surface.
Exactly. A vasectomy accesses the vesiferins externally through the scrotum. It does not breach the abdominal cavity at all.
Right.
It is minimally invasive. It's typically performed under local anesthesia in a quick outpatient setting, and the recovery is vastly shorter. So the physiological toll on the body, the morbidity, is exponentially lower for the male partner.
Which makes that FSRH mandate an essential piece of informed consent. I mean, if a couple is choosing a permanent path, they really need to know that the physical burden is heavily, heavily skewed.
They do.
But if they do choose the vasectomy route, how does the medical field actually verify success? Because unlike an ablation or an IUD placement, you can't just look at a routine ultrasound to see if it worked.
Verifying success requires a post-vasectomy semen analysis, or a PVSA.
Okay.
The patient basically has to provide samples months after the procedure to ensure the tubes are entirely clear. But the FSRH guidelines highlight a truly fascinating shift in the clinical threshold for what constitutes a quote-unquote successful vasectomy.
I saw this in the notes, and Honestly, the numbers are wild. So previously, a man was considered clear, meaning effectively sterile, if his sample contained less than 10,000 non-motile sperm per milliliter.
Right.
But the updated guidance changed that threshold to 100,000 non-motile sperm per milliliter.
Yes, they did.
They increased the allowable sperm count by a factor of 10. How does allowing 10 times more sperm equate to a successful sterilization?
The key to that apparent paradox is the term non-motile.
Meaning they don't move.
Exactly. These are sperm that have completely lost their flagellar function. They literally cannot swim.
Okay, so it's like, imagine an army trying to storm a fortress, but none of the soldiers have legs. It doesn't matter if there are 10,000 of them or 100,000 of them. They physically cannot make the journey up the reproductive tract to reach the egg.
That is exactly the mechanism. The long-term clinical data reveal that even with up to 100,000 non-motile sperm present, the actual risk of pregnancy was statistically identical to having an absolute zero count.
Wow.
Previously, clinicians were chasing this perfect zero count that offered absolutely no additional practical benefit. And that outdated threshold forced thousands of men to undergo repeat testing, prolonged anxiety, or even unnecessary repeat surgeries just to clear out completely harmless, immobile cells.
I mean, it's a great example of clinical guidelines finally catching up to physiological reality.
Yeah.
And honestly, it brings us perfectly full circle to the overarching theme of this entire deep dive.
It really does.
Whether we are talking about updating the PVSA threshold to prevent unnecessary surgeries, or legally warning patients about the physical toll of laparoscopic sterilization, or debating the FDA's severe stance on vaginal lasers, it all comes down to informed consent and genuinely understanding the true anatomical risks.
It's always about weighing the promises of a new intervention against the potential for regret. The FSRH guidelines actually specifically note that regret following permanent sterilization is most prevalent in patients under the age of 30.
A permanent physiological alteration made in what might be a temporary state of mind.
Exactly, which is why parsing through clinical data and separating marketing hype from surgical reality is the absolute most crucial step a patient can take before making any reproductive health decision.
So, to wrap this all up and answer your core question directly, based on the stack of sources you provided, yes, theoretically, your hormonal IUD does not disqualify you from vaginal laser therapy.
The anatomy is definitely on your side.
The cervix acts as this dense bank vault door,
Right.
shielding the IUD safely in the uterus, and the fact that your marina is made entirely of plastic means there is no metal to conduct the laser's thermal energy.
However, the true hurdle you face is not the IUD at all.
Right.
The true question is whether the laser treatment itself is the correct choice for you, given the very severe warnings from organizations like the FDA and ICES. You have to carefully weigh the promise of short-term tissue remodeling and improved VHI scores against the unknown long-term risks of repeatedly traumatizing your mucosal tissues.
It is a profound,
Yeah.
very personal risk-benefit analysis. But before we go, we want to leave you with a final thought to ponder that builds on the science we've unpacked today.
Right. We spent all this time discussing lasers as a primary tool to burn and physically remodel tissue.
Yeah.
But if these energy-based devices can reliably increase localized blood flow and change the permeability of the mucosal membrane, could we eventually see a future where low-level, completely non-damaging lasers are used simply as a primer?
Meaning, using a very mild laser pulse, not to cause necrosis or cell death, but just to temporarily open up the tissue to drastically enhance the absorption of traditional localized medical treatments,
Yeah.
like preparing the soil before applying a topical medication, making it 10 times more effective and potentially reducing the need for heavy systemic drugs.
It would be a massive shift from using energy to destroy to using energy to deliver.
That is an absolutely fascinating frontier. Thank you so much for sending us the stack of sources. It took us from a very simple question about an IUD all the way to the boundaries of tissue engineering and informed consent.
It was a great journey.
Keep asking those highly specific questions and keep looking past the marketing. Because as we saw today, the clinical landscape might be full of contradictions. But if you trace the anatomy, you can always find your way to the truth.